The National Blood Clot Alliance has some really good resources about thrombosis, and that's available at stoptheclot.org. Specifically, they have this really helpful page about antithrombin deficiency. It was originally written by Stefan Moll, who's a worldwide expert on thrombosis, and they just updated it in July 22nd, 2024. When we're looking for antithrombin deficiency because someone has had a blood clot or a number of blood clots, the test that's going to be most helpful is the functional assay or the activity level. The antigen level is also available to be tested, but typically that's going to be clinically helpful in distinguishing between a type 1 and type 2 antithrombin deficiency. And we're doing this as part of the thrombophilia workup. What we're trying to diagnose is inherited antithrombin deficiency. This is an autosomal dominant condition, and so often it will come with a family history. A lot of the time when we send this test and it comes back low, it is an acquired deficiency, or there's interference from a recent blood clot, which is causing the sort of acquired deficiency as the antithrombin is consumed. Or the patient is on a blood thinner like heparin, which is going to interfere with the accuracy of the assay. But acquired antithrombin deficiency can develop in a situation where there is liver dysfunction because antithrombin is a protein made in the liver. In patients that have kidney disease and may be losing protein in their urine, the antithrombin level may be falsely low. The best time to do thrombophilia testing is when the patient has exited the acute phase of a blood clot. And ideally when they're not on a blood thinner. The anti-10A inhibitors such as rivaroxaban and apixaban can lead to misdiagnosis of antithrombin deficiency by falsely elevating the activity level. Whenever I get a referral because a patient has a history of antithrombin deficiency, protein S deficiency, or protein C deficiency, I always approach that diagnosis with some degree of skepticism and do my best to try to confirm it because the testing is so susceptible to interference from other factors that I've many times had a patient come in with this diagnosis, but on further investigation and testing have found that they in fact do not have antithrombin deficiency.